Great. Thank you very much. Good afternoon, everyone. We will talk about Parkinson's disease, early diagnosis, and treatment. And in this first slide here, you see sort of the traditional depiction of Parkinson's disease. Parkinson's is very much associated with the progressive loss of dopamine neurons. These are striatonigral neurons represented here in red. And at the tip of the arrow, those neurons release dopamine to allow us to move normally. It turns out that a person will lose about 50 to 60% of these neurons, and dopamine in the striatum will be reduced about 50 to 60% before the onset of motor signs of Parkinson's disease occur. And we see another representation of this on this next slide. On the left top, you see a normal midbrain with the dark substance, or substantia nigra, containing those dopamine neurons that have melanin in them. And on the right, you see someone who had advanced Parkinson's disease, and you can see there's loss of those melanin-containing dopamine neurons, in this case, very substantially. The other main pathologic hallmark of Parkinson's disease are these abnormal accumulations of proteins called Lewy bodies. You see that in the middle of the page on the left there. You see the dense core surrounded by the pale halo. Now, we still don't have to date a biological marker of Parkinson's disease. There are imaging technologies that are available in research sites, and some of these may be available on a more widespread basis soon. But one can use either beta-CIT, SPECT, or other ligands and SPECT imaging, where these ligands bind to dopamine transporters on the dopamine nerve terminals, and it gives you an index of remaining dopamine neurons. So this is sort of a representation from the left here, early Parkinson's disease. You can see there's some decrease, particularly posteriorly, in uptake of this ligand. And as we go further to the right, you see there's progressive loss bilaterally, and that loss remains asymmetric through the course of the disease. So Parkinson's disease then still remains a clinical diagnosis based on history and examination. We expect patients to have a relatively slowly progressive disorder, and we say for research purposes we need to see 2 out of 3 cardinal features, these being bradykinesia, or slowness of movement, rigidity, or increased tone, and rest tremor, or tremor with a limb at rest. Now, Parkinson's disease almost always starts on one side, and that side usually stays worse throughout the disease. So another key feature of Parkinson's disease is asymmetry. And to that, we also add that once patients have enough bradykinesia and rigidity that you can see it relatively easily, we do expect a rather substantial and sustained response to dopaminergic medications. Now, I should say that not all patients with Parkinson's disease have tremor. It turns out about 70% do, which means that 30% don't. When rest tremor is present, the diagnosis is a lot easier. When rest tremor is not present, you need to think a lot more closely about the diagnosis and what other conditions might be present, but the lack of tremor does not exclude Parkinson's disease. Now, in the last few years, there's been recognition that there are important non-motor features that are part of Parkinson's disease. I have some of them listed here: loss of smell, depression, anxiety, sleep disorders, sleepiness, fatigue, constipation, and dementia. And just to pick a few of these out, depression is very, very important. It's very common and occurs in about 40 to 50% of patients with Parkinson's disease sometime in the course of the disorder, and it probably has the greatest effect on individuals' quality of life. So it's important when you see patients to canvass for depression and get that treated. The other important one I'll point out here is that long-term patients run into 2 big problems. One is balance, and the other is dementia or cognitive decline. And these represent very important long-term causes of disability. We borrow the medications from Alzheimer's disease to try and treat dementia as best we can. We really don't have good treatments for balance. And so one of the things this tells me is we really need to work hard to develop treatments that will slow progression of the disease.